I'm Sanjeev Bala, and I'm the Section Chief of Cardiothoracic Imaging here at WashU in St. Louis, Missouri. This was a patient who was a 67-year-old man who had come to our institution with a recurrent pleural effusion and then underwent a CT examination for further evaluation. And I think one of the things that always comes up is, when do you start to worry whether a pleural effusion is a malignant pleural effusion or is representative of something that's either infectious or inflammatory, like a fibrothorax, especially if a patient comes to you with an occupational history that could suggest that they've had pleural plaques or something along those lines. So some of the things that I think are very useful are to remember that the lung is surrounded by pleura, and the pleura can be a visceral pleura when it's attached to the lung itself, and parietal pleura when it is against the chest wall. Very useful in practice is to look at the medial pleura. If you can see that there's nodularity among the medial pleural surface, that's very unusual for an inflammatory process. It's much more typical of a malignancy. So when we see medial pleural involvement, all of a sudden our antennas go up and we get very concerned that we're dealing with malignancy. The other is to look at this. This is the subpleural fat. The subpleural fat is the fat that's on the outside of the parietal pleura between the innermost intercostal fascia and the parietal pleura itself. It should be really clean. It should be nice and black, just like the subcutaneous fat here. If you notice, they're nodules, and the nodules are almost like stalactites. They're kind of embedding into this subpleural fat. When you see that phenomenon, here you can even see there's a nodule that goes between the ribs. When you see that, that is almost always a malignancy. It's also a useful sign to pick up because those nodules would be very high yield for allowing for biopsy. And so that would be a good target for either an ultrasound guided or a CT guided biopsy. Certainly, you can look at the pleural effusion, but trying to measure the Hounsfield units of a pleural effusion, not very, very helpful to determine whether or not you're dealing with a transudative effusion, an empyema, or a malignant pleural effusion. So really looking for that medial involvement, looking for nodularity, especially for the one that burrows into that subpleural fat, super helpful in making that distinction. This turned out to be a mesothelioma. Now, what I'd like to also point out is there's a finding that's a very obvious finding that I find is kind of irritating because it's so easy to look over. And that is, if you look at the size of the thorax. So the left side is so much bigger than the right. But if you don't make a conscious effort to kind of look at the two different sizes, it's so easy to walk over that. So this volume loss is also another secondary sign, very useful in making the distinction. You can see that this patient did get a PET CT. This was performed as part of a staging to determine if the patient would be a candidate for an extrapleural pneumonectomy. And you can see that nodule that was extending between the ribs is lighting up pretty hot. And so it's very useful to look for those findings. In as much as the evaluation for mesothelioma is something that is useful to look on a CT or MR or any imaging to determine if it's malignancy, that is something that we should also be aware that far more common than mesothelioma is metastatic adenocarcinoma. So this was a patient who had come to us with a history of asbestos exposure. You can see very nicely that there are these pleural plaques that are present on the diaphragmatic surface. And what we can see is the kind of the telltale signs of malignancy. Again, medial involvement, nodularity of the pleura, very suspicious that we're dealing with a malignant pleural effusion. Notice that the left hemithorax is smaller than the right hemithorax, also very typical of a mesothelioma or malignant pleural effusion. And so we were thinking at first that perhaps that's what we were dealing with here. You can see some of these nodules insinuating into the region of the person's subpleural fat. But what I'd like to point out to you is that it's so important to remember that adenocarcinomas can be metastatic to the pleura. And in this case, when we did the biopsy and tissue was sent, we found that this was actually a recurrence of the patient's renal cell carcinoma to the pleura. Renal cell carcinoma is certainly one to keep in mind because on pathology, sometimes the morphology of a renal cell carcinoma metastasis to the pleura can be confused with mesothelioma because it tends not to express some of the same cell surface markers as a lung cancer or breast cancer, for example. And so on first glance, to the inexperienced, they can be confused. And this happened to be a person who had metastatic renal cell carcinoma as an explanation for their malignant pleural effusion. Now, unfortunately, one of the things that can come up a lot is that you may have a pleural effusion that is a long-standing pleural effusion, and on first thoracentesis, the cells are not present. You do a CT, the CT shows kind of this, what looks like maybe a bland effusion. You get concerned because you're dealing with this medial pleural involvement, and there's the question whether or not you're dealing with a malignancy. And that is something that comes up not infrequently in practice, where we may even try a pleural biopsy, as was done in this case, and the pleural biopsy was unrevealing. Patient went on to get a PET CT, and you could see that there's uptake within the pleura. You can see on the maximum intensity projection, there's diffuse uptake in the pleura itself. And despite the uptake in the pleura, we were unable to get a sample that yielded a diagnosis even on the second attempt. That's where sometimes MR can be very useful. With the MR, we were able to demonstrate some areas that were more nodular and enhancing. And because MR has a little bit better spatial resolution than PET, it allowed us to target these for biopsy. We did biopsy this patient, and this turned out to be a mesothelioma of the pleura. So for the long-standing pleural effusions, where you're concerned that there may be some malignancy that's present and that we haven't done a really, haven't necessarily been able to make the diagnosis, I would encourage the consideration of either FDG PET CT or potentially MRI, because it may allow for a target that will yield a more successful biopsy. If you're confronted with a pleural effusion and you see that there's some pleural thickening, encourage the reader to look at the medial surface for nodularity, to look for extension into the subpleural fat, to help make the distinction if you're dealing with something that potentially is malignant, and certainly look for these nodules that may yield successful biopsy. And finally, it's useful to keep in mind that in a malignancy, the side that's involved usually is smaller than the side that's not involved. In the second case, it's useful to keep in mind that though mesothelioma is something we think about with pleural tumors, metastatic adenocarcinomas to the pleura are far more common. Usually they're from lung cancers or from breast cancer metastases, but one notorious mimic of mesothelioma is metastatic renal cell cancer. And so if a patient has a history or if there's a renal mass, something useful to consider, because that is something that is potentially a likely a candidate and one that's easily mistaken by the unsuspecting pathologist for potentially a mesothelioma. And then finally, when you are confronted with a long-standing pleural effusion and your initial attempt at doing either thoracentesis or biopsy are unsuccessful in yielding a diagnosis, consider either a PET CT or potentially MRI, because they may show areas that are more amenable to sampling to improve the diagnostic yield of any type of biopsy.